Hello, everyone, and welcome to Nova Scotia Health's Trauma Program's Interprofessional Clinical Webinar. My name is Andrea Bond, and I will be your moderator for today's webinar. We're pleased to have Steve Crocker joining us today as a presenter. Steve is one of our EHS LifeFlight paramedics and a clinical leader within the team, the critical care transport team. We also have Nick Sowers on the line. Nick wears a few hats, and in this role, he's a trauma team leader, emergency physician, but he is a medical care physician with our transplant team, so he will be joining in later on as well. The title of Steve's presentation, as you can see, is Moving Critically Ill and Injured Trauma Patients. Those in attendance are muted, and there'll be an opportunity for questions at the end. There should be a question section in the top right of your screen. If you'd like to type your questions in, I will read them in at the end of the conversation, and Steve will be able to respond to your comments. Thank you for joining us today, and Steve, you may start the presentation.
Good, thanks Andrew, thanks everybody, and thanks Rob for the invite. So yeah, the title, Moving Critically Ill and Injured Trauma Patients, the real title is, which was a little catchier, but I couldn't fit it into the slide, was Planes, Choppers, and Trucks, or Planes, Trucks, and Choppers, so which seemed a little bit cooler than just this one of Moving Critically Ill and Injured Trauma Patients. So yeah, I'm Steve Crocker, CCP with the LifeFlight team, and Andrea mentioned Dr. Sowers, so Nick Sowers is gonna sort of jump in. He's unmuted, so he can sort of jump in when he wants to, or when he feels that he needs to add something to this presentation. So let's get started. Hopefully we can end it within an hour, and we'll open up for some questions. So to start off, I have nothing to disclose, no relevant financial relationships. Rob doesn't pay me. He promises me a craft beer every once in a while, but I have yet to see that. But other than that, no other interest or financial relationships to this presentation. And so this is the plan. We're going to give a quick overview of our EHS LifeFlight program, sort of activating critical care transport within some case studies. So I have a scene one and a interfacility, sort of understanding some logistical decisions within our transport program. And then at the end, sort of some tips to help manage trauma patients, whether they're pre-hospitally or interfacility. And sort of that's the plan as we work through it. And then hopefully there's a bunch of questions at the end. So our program, so our EHS LifeFlight program, part of EHS, been around for 20 odd years or more. We are CAMES accredited, so we are accredited service. We just finished our last accreditation, which we just got full accreditation back in, I think just in the spring, early spring. It was supposed to be in the fall, but due to COVID, it sort of creeped into spring. So what we do is we provide critical care to ill and injured patients throughout our province and throughout the Maritimes, really. We provide clinical expertise, good decision-making support, and safe and timely transfers, both interfacility and scene throughout the province. Our teams, so our teams are sort of the backbone of our program. I'll start with the adult team. So the adult team within our program is a critical care flight paramedic and a critical care nurse, flight nurse. We have two teams on. Within the last year, we started with a peak team. So we have our regular core team from sort of 7 to 7, 24 hours a day. And then our peak team, our adult peak team starts at 9. So they go from sort of 9 to 9 to 9 is their shift. And we're responsible for all interfacility patients, adult patients 16 and above throughout the province of Nova Scotia. We do service PEI. And so at times we do a little bit of work in New Brunswick. Our pediatric neonatal team is based out of the IWK, and that's a critical care nurse and a respiratory therapist on their team. And they do everything from neonates up to the age of 15. And they just do interfacility. The adult team does interfacility and scene. The peds neo team just does interfacility transports throughout the 3 provinces. There's a specialty team, an obstetrics specialty team, and that obstetrics nurse, again, for obstetric patients. And they fly usually with our peds neo team. But from time to time, depending on mission logistics and whether one team is out or not, there are times when they do go with the adult team. It's very rare, but for the most part, they go with the Peds Neo team. So that's sort of the composition of our teams. When we talk about, and I'll talk about the adult team in general, and we practice under an advanced scope of practice. So not only do we provide sort of timely transports, but it's also getting our team to the patient for this sort of advanced scope of practice and expertise. So we do stuff, advanced airway management, whether that's direct laryngoscopy, video laryngoscopy, chest tube and finger thoracostomies, IO insertions, X-ray interpretation, art lines, pericardial centesis and traumatic cardiac arrest. Mechanical ventilation is the big one that we sort of pride ourselves on through transport. And then the newest one that sort of our advanced scope that's been up and running now for about 2 years, I think, probably going on 3 years, is our blood product administration or a blood product transfusion program. And so right now our adult teams carry on every mission. We carry 2 units of O-negative blood, and that goes on every mission, and that helps us with not only scene trauma, but it also helps us with blood transfusion, whether we're coming from an inter-facility, maybe we're transporting a patient from a rural facility that probably has no blood in their facility, or that they just have limited amounts of blood. So we can either leave their blood at that facility for another time, for another patient. And sometimes we end up taking both. We end up using sort of the facility's blood and our blood. So it's probably the one of the biggest pieces of our program that that all our crews have enjoyed over the last 2 years for sure, and it's making a difference in our trauma patients. Our transport options, and again, we're not just a helicopter service, although our primary response vehicle is by rotor wing. So in the top left, we have Sikorsky S-76C Plus helicopter. We have 2 of those in service. One is always a backup. So our out of service time has decreased immensely since the arrival of these 2 new 2 machines. The right top is our King Air Beechcraft 200. So that's our fixed wing option that we have that can respond to transports where there's an applicable airport that we can land at. We do have a critical care ground unit in the bottom left, sort of the bigger unit. And so that's sort of based 24/7 out of our hangar here, and we can respond to any type of mission, whether it's scene mission or in a facility within a radius of, you know, we've probably gone 2.5, 3 hours for some transports to retrieve patients. And when this truck is not in service, it's staffed by a LifeFlight operator who is based out of our program or works for our program. And if CC1 is not available, we'll always have a sort of a system status truck that we can use, and it's dedicated to us 24/7, which is great. Actually relieves a lot of stress on our ground ambulance system, and we use any sort of type of these options for transporting patients, and our primary sort of response vehicle is definitely our rotor wing. So those are our transport options, and that's all depends on and based on weather. It's all depends on mission coding, sort of what vehicle will respond first, and then sort of what is the backup vehicle if one of the other vehicles are unable to either fly or transport us. We use a communication dispatch center, so we have a dedicated air medical transport communications officer who is dedicated to us 24/7. And they sort of coordinate all the aspects of our EHS LifeFlight mission requests. So from time of call from an inter-facility to paging out requests, mission planning, all that kind of stuff goes through our comm center. Any of our communications between ourselves, our critical care teams, our physicians or hospitals or sending facilities, that's all sort of navigated and coordinated through our comm center and through our AMTCOs. So we're lucky to have that as part of our program as well. Our coverage area, I kind of talked about it briefly when I was going over the critical care teams, but for the adult team, we do all inter-facility and scene missions within the province of Nova Scotia. We do inter-facility missions to PEI and just a little bit of backup into New Brunswick, but not a whole lot. Our pediatric, neonatal, and obstetrics teams, they just do inter-facility for Nova Scotia, PEI, and they do quite a bit of work in New Brunswick. So they're busy as well in all 3 provinces, but that's sort of our coverage area for our program. So when we talk about our province, and this is a slide that's taken from Trauma Nova Scotia, and it was a study that was done back, I think, in 2017. And I like to use this slide in almost all my presentations, especially around trauma care, is that our province is unique. And when you look at the top picture of that and you see all red, that's sort of the distance between what the blue is of where our tertiary care centers are, both the QE2 hospital in Halifax and the IWK Center for Pediatrics. And that's where our 2 tertiary care centers are. And as you can see, the rest of the province, it takes a long time to actually sort of access those 2 facilities. What's good about our province is that in the second picture, there is a number of regional centers throughout our province that, whether it's patients being brought to those emergency departments by family, or whether it's they're being brought there by EHS, these regional centers play a huge role in sort of trauma management and stabilizing patients till we can get these patients moved from regional centers to our tertiary care centers in Halifax. And as you can see, a lot of that map has turned blue. There was a tone in my ear, Andrea. Everything's still good? I didn't time out, did I?
No, we can still hear fine.
Okay, good, perfect. So yeah, so again, the blue makes it that we can get to these centers a lot quicker. And so as you can see, even within this sort of map, a lot of the red yellow areas, Keji down in sort of the western part of our province, it's difficult to move trauma patients from these areas. The Eastern Shore, another difficult part to move patients and get them from, where their injury happens to either a regional center or tertiary care center. Then the biggest one, probably the hardest place to move patients, is up into the Cabot Trail, up into Cape Breton, and it is a challenge. It is a challenge on a good day, and it definitely is a challenge on bad weather days where we're trying to meet these patients and get these patients even to a regional center in Sydney or to definitive care in Halifax. So I like to use this again with the blue and the regional centers. They offer a lot of expertise and they offer a lot to the patient that we can get these patients stabilized before we transfer them to Halifax. And then the other part is that we can actually fly to these areas, even in the red zones, where we can get these patients from time of injury and where the scene is, back to either a regional center to stabilize or to Halifax to tertiary care. So it's a good slide, and I like talking about it because our province is definitely unique when it comes to trauma care. So logistically, weather happens. We live in Nova Scotia, where we get a lot of rain and a lot of fog and a lot of icing conditions. And so, whether it's cloudy, icy, snowy, whatever it is in your area, or you may feel that it's nice and sunny. Why isn't LifeFlight coming to this? It depends on how from point A to point B, how we get there and what the weather is like on both ends of our mission. And safety is the biggest thing that dictates all of our transport decisions. None of our decisions within our program are made without safety being our first priority. Our rotor wing captains and our fixed wing captains, they have the final say on whether we respond to a mission via flight. They will do weather checks. Sometimes it takes them 2 minutes to do a weather check. Sometimes they'll it's 15 minutes before they can figure out, what are some alternatives to get from a patient from Sydney if we're going instrument reading or instrument flight plans. There's all kinds of things that they look into, and safety is definitely the biggest thing that they pride themselves on. In saying that, we can still respond by ground ambulance. So CC1 is available here for us 24/7. Or if CC1 is on another mission, we will use an SSP or a system status vehicle within the province to either move patients or get us to a patient wherever we need to go. Sometimes it's a combination. Maybe, we need to go to Inverness and we'll only fly to Port Hawkesbury, and we'll have to take an ambulance from Port Hawkesbury to Inverness. So there's a combination of different ways that we can get to a patient or a patient can get to us. And intercepts are an option for us. We've routinely done patients or transports where patients are coming from a regional center. We're unable to fly to that center or that area, but we'll intercept along the way. And so maybe that's just with a ground ACP and bringing that patient towards us and meeting us somewhere, or maybe it's hybrid teams. And this is probably a sort of a new thing for some people who are within interfacility transports or who work in hospitals, that there may be times when our medical control physicians actually discuss trying to move these patients, and probably the best and safest way is to sort of develop a hybrid team within that facility. We know it always doesn't happen, and especially in today's world, resources are slim at times. But you know, it could fall on that you need to sort of get a hybrid team. Maybe it's a physician, maybe it's a nurse or an RT to go along with a ground ACP to move that patient from point A to point B. Maybe it has to go from, you know, Sydney to Halifax. Maybe we're on other missions that we just cannot facilitate those transports. But we'll always do our best to try to figure out the best way and the safest way to move these trauma patients from either a regional or rural center or scene mission or scene standby to definitive care and tertiary care in Halifax. And again, safety is the biggest thing that plays a role in that, which is good. So we'll just discuss a couple of cases, which we'll go through over the next few minutes. Some of these you've probably encountered, but the first one we'll talk about is sort of scene. And this is, we get probably, our scene missions have probably increased over the last few years for sure. But any paramedic or anybody actually, whether it's a first responder, police agency, whoever, they'll put us on standby, and I'll talk about that in a sec. So this is the first case. Paramedics are responding to a single vehicle rollover on a secondary rural highway with entrapment. And while they're going to that call, our comm center are actively putting us on standby. So they'll put us on standby. So we're doing our weather checks, we're getting our stuff, we're pulling our helicopter out, or whatever our mode of transport is going to be. We're going to get stuff ready for that. They put us on standby, we're available. And so the paramedics arrive on scene. They find a male patient unresponsive and trapped in the vehicle. And then the paramedics can actually launch us right from the scene. They have the ability to launch us based on certain criteria. And when they launch us, it saves that time for us to respond to get to that scene anywhere in the province. This is the sort of the first case that we'll discuss. So what are the criteria? I won't go through all of them slide by slide, but our criteria are pretty similar to even trauma team activations within HRM or Halifax, is that a patient needs to meet one of these sort of criteria, whether it's anatomical, physiological, mechanism, logistical, and paramedic judgment. And I like to use that one for a lot of paramedics that, you know what, if something is just not sitting right with you, maybe, you know, the mechanism, maybe it's just mechanism, but that paramedic judgment, if they feel that they need our team or they feel that this patient needs to go to Halifax or a tertiary care center, then make that call and launch us. And if it turns out that we're not needed, then that's okay. We'll come and assess your patients. Maybe we'll help you get that patient to a regional center, but don't be afraid to actually launch us based on paramedic judgment. And I think that's huge for our paramedics across the province. So that's sort of the criteria for them to launch. Once it's launched, that means that we are now wheels up, is what we like to use the term use, whether that's in our rotor wing, maybe it's in our fixed wing, maybe we're getting launched to Sydney and we'll take the fixed wing, or maybe it's by ground ambulance or CC1. And just because we can't get to the scene, doesn't mean that it doesn't meet a launch criteria. If you think that that patient exceeds the capabilities of your closest center, then you need to launch us. And that just cuts down a lot of time from the time we get launched to the time we actually make patient contact. And that's a big point to sort of drive home, is that, you know, okay, yes, they're in the Eastern Shore or somewhere in Cape Breton, that, you know what, The hospital is only 15 minutes away. The LifeFlight team is not going to land right here on the side of the highway to get this patient. But you know what? This patient, the clinician believes, it's not going to stay at that facility and may need to get moved to Halifax. Then that's a launch for us. Again, any level paramedic, whether you're a PCP, a brand new PCP, or an experienced ACP or CCP on ground, you can launch us. And as long as that patient sort of meets that one of those criteria, it's a quick call to our communication center that they want our team launched, and then we'll talk to the team after that. Once we get up in the air, we're going to have a conversation with that ground paramedic and see what we're actually responding to. So when we're en route, we'll routinely get that unit to switch over to AMT Air, or sort of our TMR talk group that we're on. And we'll get stuff like patient update. We'll also be conferenced in with our LifeFlight MCP en route to that call. And sometimes we don't get the MCP involved in this. If there's some sort of issue with communications, just talk to the LifeFlight team, talk to the critical care team, and then we'll be able to talk to our MCP through our SATCOM and give them an update on what we're going. When we make patient contact, this is sort of what we do and what we're going to do. We're going to assess and treat as per our LifeFlight CPGs. And then we're going to call conference with the LifeFlight MCP, who's on call for us that day. And we're going to talk to the TTL who's on, whether that's an adult or peds, depending on the patient. And we're going to give them an update. And this is where the TTL activates the trauma team and accepts that patient, that yes, this patient meets criteria for us, and we would like this patient transported to the QE2 or the IWK for a trauma team activation. Our TTL sort of has the final say in accepting those patients, and our LifeFlight MCP has the final say in our transport decisions. So again, not only in transport decisions, but also in sort of medical decisions, the team will always revert back to our LifeFlight MCP, who know what our skill set is, know what our CPGs are, and are able to give us some direction in sort of patient management. And so sort of that is sort of the activation from scene and sort of the communication that goes on within a scene transport. If there's ground medics who are sort of new to our system, who've hopefully you have seen this before, hopefully you've know how to launch us. And again, if it's a little bit vague or you're not 100% sure, by all means, at the end of this presentation, ask a question or send me an email and I'll get back to you with some answers for sure. So that's trauma team activation from the scene. The other sort of mission that we go on quite frequently is interfacility. So maybe that's a ground ambulance taking this patient to an interfacility or to a hospital, or within our province, there's lots of times where sort of patients arrive sort of to the front doors of an emergency department, you know, with a traumatic injury, and then it's the interfacilities job to manage those patients and then get those patients moved from their facility to tertiary care. And so this is the second case, probably not uncommon around our province. Female patient brought into local ER by friends after she rolled her ATV into a ditch. The ER staff perform a systematic trauma assessment and feel that her injuries are warranted for her to be sent to a trauma center. And so she's reported to have an altered LOC, increasing dyspnea with obvious chest injuries and an unstable pelvis. Again, any of those things or one of those things concerning for a rural facility, sometimes concerning for a regional facility. And so this is sort of how this trauma team activation from an interfacility should happen. Early activation is critical, not only on scene missions, but also even within interfacility. Early activation means that it's just getting the ball rolling. We know that there is now a trauma patient in some center within our province, and we can start sort of organizing and getting set up to get that patient moved from that facility to Halifax. So hopefully we like to tell you within 15 minutes. Again, maybe there's a lot of stuff going on. Maybe you're unsure whether this patient meets the criteria or not. but hopefully within 15 minutes, you should know whether that patient is going to stay in your facility or whether that patient should be moved on to Halifax. We like to talk about not delaying transfer to get definitive diagnosis. We sometimes see, especially in facilities with CT scanners, yes, they are important, but sometimes the delay in that to get, okay, I need to talk to the trauma team, but I need to know exactly what injuries this patient has. And again, Nick and Rob are on the line. You guys can talk to this at any time, but sometimes it's not warranted for you to delay that transfer to figure out what is actually wrong with those patients, because they're going to end up getting CT'd when they arrive in Halifax when they get there. Same with a test. If you decide to do a test, whatever it is, if you cannot change that, or it's not going to change what you do for that patient, then maybe it's not the right test to do. Now, in saying that, especially with CT scans, maybe there is time. So if we have a 45, 50-minute flight time to get to that patient, then you know what? If the patient is stable and they're able to go to CT, then that's fine. But again, I would recommend anybody in a rural or regional center, if you have that capability, to discuss that with the TTL, discuss that and see what they have to say, and they may agree or disagree. And we'll base our treatments off of that. For regional centers, this is probably a big one that we see a lot of, is get your surgeons involved early if needed. So maybe there is some sort of abdominal injury, the patient is hypotensive, in shock, you've fluid resuscitated them, you've given them blood, and they still are profoundly in shock. This is where you need to get your surgeons involved. And sometimes this is a difficult decision to have, but it's the right one to have. These patients, unfortunately, will not do well if we have to transport them when there is a surgical capability at a facility and they're able to fix that or temporize that before we transfer them to Halifax. And that's a big one that we see a lot of, is sort of the emerge physician not wanting to get their surgeons involved, or thinking that we can just go in and scoop these patients and transport them. But again, it's all about safety and what's best for the patient. And in our opinion, it's getting these surgeons involved early to actually assess this patient and see if it warrants them taking them to the OR for some sort of temporizing treatment. When it comes to call conferencing and activation, this has changed over the last year or so as well, is that there's more people on the phone now. And so the good thing about trauma activations, that talking to just a couple of people, but hopefully it's just one phone call. So this phone call that comes in from a facility, it's going to be through our comm center. It's with our LifeFlight MCP, it's with the LifeFlight critical care team, and it's with the TTL, whether it's, again, adult or peds patient involved. And so all those people are going to be on the line. And we're going to, again, it's the TTL who accepts this patient in transport, or accepts this patient to be transferred for a trauma team activation. And it's our LifeFlight MCP who sort of overtakes that to make that decision whether they need to be transported by us or not. The biggest thing is here is remember, especially for our colleagues who work in hospitals, the TTLs who are on call and our MCPs, they're to help with treatment decisions. They can offer advice, they can answer questions, not only on that initial call, but maybe we're going to that patient and 15 minutes later or 20 minutes later, something changes, or you think that something should be done for that patient. By all means, call back to our comm center and get in touch with the TTL and the MCP who are going to help you with those decisions. And I've witnessed that, and it makes a huge difference in the care that these patients receive. Facility resources and required planning. Know what your hospital capabilities are. So make sure you have equipment ready and checked. Sort of this goes back to our days when we used to teach, and we still will teach, the rural trauma program to these facilities. And it's having your room and your equipment ready and checked, whether that's airway management, chest tube, fluids and blood products if they're available, tourniquets, pelvic binders, anything like that should be all ready and checked. And again, we talk about our surgeon, if the surgeon is available, to include them. The best way to treat these patients is to be well planned and I have this equipment really readily available for these patients when they come here. Under warm fluids, the other big thing we talk about is warm environment. And so, you know, the trauma room in a rural facility that hasn't seen a patient in maybe 2 months, and now all of a sudden there's a patient that's in there, make sure that that room is warm. Crank the heat and make sure these patients are warm, and we'll continue to do that even in transport. This is a trauma checklist that we put out a few years ago, and I still see it in trauma centers and trauma rooms around the province. And it's a great tool to use as you go through sort of a trauma assessment, and a systematic approach to your trauma patient is just hitting on these key things. It may be sort of a little difficult for you to see on the screen now, but it sort of goes over, you know, early activation, airway management sort of tips. You know, what are you going to do for something that's wrong with breathing or circulation? It has some doses there for TXA. It has some doses there for sort of analgesics and sedation. And if you're able to follow this checklist when you have that patient in your trauma room and you're waiting for transfer, this is a great checklist to use to make sure you check all the boxes that this patient is being managed very quickly and appropriately. And I think I blew through that pretty quick. It's 12:30, kind of went a little faster than what I thought. I'll open it up to questions, and I'll even open up to Nick or Rob if you guys have any sort of comments that you'd like to add on anything that I talked about. Feel free.
Steve, just a couple of comments, and really I want to echo a couple of the points you made, because that was there's a number of things in there that I think are critically important. The first is that, you know, whether it's the TTL or the LifeFlight MCP, you know, please, you know, don't just think of those physicians as the person who's accepting the patient to leave your center. You know, we really are there as a resource, and whether that's, you know, just to accept the patient, whether that's to offer some advice about how to resuscitate that patient, you know, all of the TTLs, all of the LifeFlight MCPs, we are more than happy, you know, to help kind of work through a case, to be that sort of, you know, source of advice, or just to be that person to kind of cognitively offload, you know, some aspect of resuscitation. You know, especially if you're in a center, you know, by yourself, for example, we're always happy to have these conversations. And that's not just for, you know, for patients who are coming by LifeFlight. You know, if we're able to come get them, then absolutely we want to help and we want to be involved. If you've got a trauma patient who, you know, maybe LifeFlight's not able to get them, but we're going to bring them by ground, you know, that LifeFlight MCP is still absolutely a resource to help you, you know, provide the best care possible for that patient. And the same goes for all of the TTLs. You know, we are much more interested to be involved in those conversations and to help in that resuscitation, so that we know, you know, that the patient's getting the best care possible, but also so we know exactly what has happened, what's going on with that patient, all the way through that resuscitation by the time that they arrive to our care in Halifax. The other point I want to just to echo Steve's comment about centers that have surgeons that have anesthesiologists that have the capability of going to the OR. That is incredibly important, and something that, you know, I don't want people to feel as though they're getting pushed back. And so if you call from a regional center with surgical capability and describe, you know, a case that sounds like that patient needs an operative intervention, so there's some free fluid in the belly and the pressure is a bit soft, you know, we're going to sort of ask questions around, you know, has the surgeon there seen that patient? Have they examined them? Have they looked at imaging, if imaging has been done? It's not to be obstructive. It's not to push back and say we don't want to accept that patient. It is 100% because we have seen patients that if we jump too quickly to say, well, let's get a helicopter and get that patient and bring them to the QE2, we have seen a number of patients who had bad outcomes as a result of that delay to operative intervention, who have honestly just bled to death on the road trying to get to the city. And so, you know, one of those things that we're going to ask for is, you know, has the surgeon assessed that patient? But again, it's not to not bring the patient to Halifax. It's because we think of, going to the OR in a regional center often as just an intervention as part of the initial resuscitation. And so we hopefully make that communication to the physicians that call us and to the surgeons in regional centers that, listen, if this is a patient who's got, polytrauma injuries and are beyond, globally the scope of comfort or the scope of management in that regional center, that's very understandable, and we're still happy to take those patients. But it is often the case, or can be the case, that it is most appropriate to bring those patients to the city as a trauma team activation after they've gone to the OR to control something that is, the cause of life-threatening hemorrhage, et cetera, that sort of thing. And so just because a surgeon's, scalpel has touched the patient does not mean they can't come to the city. And in fact, there are lots of cases where it is in the patient's best interest, it is safest for the patient and the best outcome for the patient if a surgeon at a regional center provides an important kind of step in the initial resuscitation in the operating room for us to then bring them to the city, to the trauma center after the fact in a slightly delayed fashion. The only other comment I'll make is just, Steve had one really great slide there a couple of minutes ago, just that mentioned kind of calling early and not delaying transfer for things like imaging. And that's really important. And that is something that we talk about a lot, as a trauma program, is we really try and emphasize, please call us early. And I think partly because we do that really well, there sometimes is a shift in mentality to say, well, if I call early, the patient will be going early. And our hope is that that's exactly what happens. But there are lots of cases when that may not be the case. And the issue is we just won't know that until you call. And exactly as Steve mentioned, when you call early, it makes us as a system aware of that patient and allows us to triage that patient. Because what may happen is that if you call from Yarmouth, for example, and tell us about a trauma patient, if the weather's good and we're at the base and don't have any active missions right now, we may be able to take off in a couple of minutes and come get that patient really quickly. But if you call us from Yarmouth, it may be the situation that, well, we're just taking off from Sydney with a rupturing AAA, and we know exactly how much time it's going to take us to bring that first patient to Halifax, to turn around, to refuel, to get to Yarmouth, to get that trauma patient from you guys. And so by calling early, our hope is that it means we can get patients, out of smaller centers into the city faster. But unfortunately, that's not always the reality. But what it does do is it allows us to triage. And as part of that triage, it may mean that we may ask you to do certain things. So if you have a patient, in Yarmouth, for example, with clinically a spinal cord injury, and you call early, that's awesome. That lets us know exactly where that patient gets triaged, and we then have the information to say back to you to say, listen, it's going to take us, 90 minutes to get to you, to get that patient. In that time, can you do a pan scan? Can you get the imaging done, both so we know that there's not some other injury that needs to be addressed, but also so our surgeons in the city can have that information sooner to plan for operative intervention, et cetera, et cetera. So please do call early to activate that system so that we can start triaging patients. And again, trauma patients are kind of about as high as we triage patients, but there is the possibility, and I'm sure you've all been in that situation where you call early and then we can't necessarily get to you early. We understand that that's frustrating, and we've heard those frustrations before, but we're going to do the best we can to get to you early. When we know that there's going to be a delay, we may ask you to do certain things and to arrange imaging if we know in the big picture it's going to save time for that patient. And especially for those patients where there is going to be a delay, please, reach out to the TTL, to the MCP, as a resource. If you have questions, if there's anything we can do to help, in the resuscitation and care for those patients, that we're there as a resource for you. That was a fantastic talk, Steve. It's a great overview of the program. Really glad to be here and hear that and to be involved kind of from both perspectives, but I'll leave it at that. Thanks, buddy.
Yeah, thanks, Nick. I'll just agree with what Nick had to say, and especially around the part of surgeons and getting trauma patients who you feel probably need to go to an OR. That doesn't mean that we're not going to, exactly what Nick said, it doesn't mean we're not going to transport that patient. We have delayed sort of going towards that patient or waiting for that patient. Sometimes we waited at the hospital for these patients to actually get their OR, sort of temporize what they need to temporize, and then we'll take them right from the OR on our stretcher and then take them to Halifax. So it's a great point that it's definitely not pushback. It's all about patient safety and what's best for the patient before we actually transport them. Rob, any comments, or you'd like to add something?
I don't think so. I thought that was an excellent overview, and I agree 100% with both you and Nick that the trauma program is a resource, and it's a resource right from the time that a patient is injured for advice, for treatment options, for the coordination. And really what we want people doing is that early call sets a patient up for success. And what we don't want is delayed calls. Like, I found this on a CT and it needs to come to Halifax. That just delays patients from coming. One thing I'd ask, Steve, it struck me, how do paramedics in this kind of chain get feedback? Like, it just strikes me, I only ever see certain paramedics who happen to drop off or transport a patient to the QE2. And a lot of times, it seems like a missing piece of how to, thank the paramedics for, the ones that drop the patient off at the initial hospital, or, provide some feedback. And it's always been a question that I've had.
Yeah, it's a good question. I don't know if I have the answer for you. It definitely is a missing piece. I think it's a missing piece for not only ground paramedics. I think it's a missing piece for us as well as a critical care transport team, and sort of finding out sort of how our patients did and what their outcomes were. I know that it's a long outstanding issue with trying to find that information. I think there's some progress being made so we can get that. The only thing I can sort of add on my end personally is that I do from time to time, depending on, complex patients, sick trauma patients, I'll always try to get the medics who we, if it was a scene mission, try to reach back to them just to give them some feedback on, whether they did a great job on scene or whether, maybe there's something they could change. But I'll also just give them a feedback on, hey, like, we transported your patient, got him to the Q2, they did a CT, and this is what his injuries are, stuff like that we are able to sort of get. I think it's important to get that feedback to paramedics. I don't know through their ground auditing process, does that get flagged? And then again, it comes sort of, the issues that everybody sort of faced through privacy and trying to find out that sort of those outcomes. I think it's going to get better over the next little bit. I know there's some work being done, but I think if they're flagged for a ground audit, I think they'll be able to get, what the outcome of that patient was. But, personally, I can tell that I've done that several times where I've called the paramedics back to give them some feedback and sort of to give them an update on their patient. But that's about it. I don't have any other real sort of tangible sort of, this is the framework of getting feedback to paramedics, unfortunately.
I think as a system, like, it's not just paramedics, but sending facilities, the nurses in, say, Bridgewater, and the doctor in Bridgewater, as a system, like healthcare system, we're not good at providing that feedback. And that's one thing I think going forward with our trauma program that we need to certainly dig into and see how we can improve that.
Yeah, for sure.
I'd say open it up for questions. Good job, Steve. Really, really good talk.
I do have a couple of comments and questions in the box. The first one is, Steve, you mentioned that pilots have the final say in all missions. It's important to mention the concept of pilot sterility to the ground crews and sending hospitals. Basically, it's important to know that the pilots don't know how sick the patient is. I think it's important that paramedics working in the field understand this. Yes, the CCT knows what's up with your patient, but the pilot does not.
Yeah, that's an important piece for
So then
sure.
kind of follow up from the same person. It's important
Yeah.
to remember that even within HRM, the CC1 is more useful doing a CABA-CUD to the HI or Dartmouth General to HI transfers or a VG run.
Yeah, so I'll add to the first part of it for sure, in that our pilots don't know. And so when we get a call conference, whether it's interfacility or it's a scene mission, all they really know, whether it's an adult patient, a pediatric patient, an obstetrics patient, or a neonatal patient, that's basically all they get. I'm sure our pilots are aware that if we get launched to a scene mission, that it's a trauma patient. I think they're bright enough to understand that. But they have no sort of understanding, and nor do we want them to know what the injuries are for our patient or how old our patient is. It just comes in as a pediatric, adult, obstetric, or neonatal. And so we do training yearly. It's called Air Medical Resource Management, and that's probably the biggest piece that's in there, is that our pilots don't get that. And just for that reason, it's just for safety. They make decisions whether we can fly or not fly based on weather and based on safety. And so if we start interjecting, well, hey, come on, it's a 5-year-old who is a trauma patient in this town. They may feel that, oh, there's an urgency. I should do everything I can to get our team to that patient, when that's not appropriate. And again, that's where mistakes get made, and that's where accidents happen. So that's the first piece for sure, that our pilots definitely do not know how sick our patients are. And then the second piece, yeah, CC1 is a huge asset to us, in that we can respond to critical care patients that are being moved from, CABA-CUD or Hants or Dartmouth General, anywhere within HRM. We are a resource to use. We are a critical care transport program. And if we need to move those patients from those facilities, just even across the harbor to Halifax, if it meets our criteria, then that's what we'll do.
Thanks, Steve. The next question, are there any plans to explain what blood components and products are available on board, i.e. platelets, plasma, or fibrinogen plus PCC?
Yeah, good question. Right now, it's just 2 units of O negative packed red cells. There are discussions, or we will be having discussions through our adult team lead and the transfusion program at the QE2 to get some extra products, but that's not there yet. Hopefully it will be in the future. I know that BC EHS just trialed or are trialing carrying plasma on their missions. So they carry 2 units of O negative as well, and they just started trialing to carry plasma. But we're not there yet. We're still we still just carry the 2 units of O negative, but those discussions will be happening soon, and hopefully in the near future we'll have other blood products that we'll be able to use and utilize.
Great. The next question is, where can we access fresh copies of the trauma checklist? I can probably answer this one. Anyone who's interested in getting a fresh copy of the trauma checklist, probably best just to email to the Nova Scotia Trauma email, and I can get it distributed out to anybody who's looking to get a copy of those. Next question, if the patient does meet the criteria for TTA, but I feel the patient still needs a higher level of care, does this patient need to be accepted by a service in Halifax in order for them to be transported there?
I'm not sure I understand the question. So the patient meets criteria for trauma?
It says if the patient does meet the criteria for TTA, but I feel the patient still needs a higher level of care, does the patient need to be accepted by a service in Halifax in order for them to be transported there? Oh, it's supposed to be if it doesn't meet the criteria. I just got a second. If it doesn't, so okay, I'll read it again. If the patient doesn't meet the criteria for TTA, but I feel the patient still needs a higher level of care, Does the patient need to be accepted by a service in Halifax in order for them to be transported there?
Andrea, I guess it's a perfect example of a conversation that the TTL can be
Yes.
really helpful with. So if you have a case and let's say for whatever reason, we don't think that they need to be a trauma team activation, then the trauma team leader is not the accepting physician, then yes, you would need an alternative accepting physician. But the TTL can certainly be someone that, if that were the case, the TTL can certainly be someone that, can help you navigate that decision-making process, can help sort of navigate the system to say, listen, this may be the appropriate service and person to speak to, and let's get them on the conference call as well, and we'll sort of figure this out. One of the other things that we are kind of increasingly doing, and I'll leave to Rob to maybe go into detail if he wishes, but is, we are seeing trauma team activations more as a consult to the trauma team leader and maybe one specific kind of service that's typically involved in the trauma team. So for example, if you have a patient and you've imaged them and you know that this is probably most appropriate for orthopedics or for neurosurgery, for example, you often get maybe some hesitation from that service in particular just to be the accepting, given that they were, a polytrauma patient. We're increasingly, as a TTL, just sort of seeing those patients as a kind of a lower tier trauma team activation, and seeing the patients often just ourselves when they arrive in the emergency department here in Halifax, with the kind of discussion ahead of time to say, ideally this patient's coming for ortho, we'll see them as the receiving for trauma, just to do a head to toe to make sure that everything has been identified, that make sure that everyone is comfortable, with the kind of discussion ahead of time to say, in all likelihood, this is going to be for ortho, for neurosurgery, whatever it happens to be. But in that small group of patients that I think need to come to the city that maybe aren't going to meet criteria for trauma teams, the TTL can certainly be someone who helps kind of liaise those conversations, navigates those conversations. Or I think for many of us, and I'll just speak personally for this, for many of us, we're often just comfortable seeing these cases, as the sort of person at the door to do a head to toe to make sure that things are kind of all taken care of, as long as we've had those discussions with who we think is the most appropriate service to admit that patient, maybe up front. So just, again, conversations that the TTL can be very helpful with. You may run into a situation where we say, listen, yeah, maybe that doesn't sound like it should come for a full trauma team activation, and it sounds like it's mostly orthopedics, so let's go ahead and get ortho on the phone as well, and we'll sort of have this discussion as part of a conference call, but we can certainly help you with that.
And I'll just add on the pre-hospital side of that as well. So if, maybe we get launched to that scene and that doesn't meet trauma team activation, but they're in a rural, their closest hospital is a rural center, then that's a discussion that we'll probably take them to a regional center. So they probably do need to meet a higher level of care from the rural facility. And then, if we're on scene, there are times when we'll actually just transport that patient to a regional center, whether it's Bridgewater, Glasgow, Aberdeen, wherever it is, we can transport that patient to a higher level of care than what sort of that rural facility is. And then on the flip side of that is within HRM, if it's a trauma team activation or you feel it's a trauma team activation and you talk to, you go through the procedure of sort of getting or wanting that trauma team activation and it gets denied, those patients still get transported to Halifax to the infirmary. So if you're in Sackville and you feel it's a TTA and it gets declined, that patient is still going to go to Halifax. It won't go to Cobequid. So hopefully that makes sense to whoever asked that question. Hopefully it answered it.
Sure. It's actually one of the ones that you forwarded your link to.
There you go.
I have a question about where can I find a complete LifeFlight CCP and RN skill set list?
That's a great question. I think it is on our website. And if it's not, you can just email me and I will send that to whoever is looking for it.
Okay.
yeah, Lindsay says that it's on the website.
Okay, perfect. That's all that I have in the question box at the moment. I don't know if you guys have any other closing comments, either Steve or Nick or Rob.
I'll start, or you can start, Nick, if you have something to add, or Rob.
No, just great job, Steve. That was a great presentation, great discussion, really important stuff. Thanks for having me.
Very important stuff. Thanks for being here, Nick.
So go ahead, Rob.
I have nothing to add other than my compliments again. How awkward.
Yeah, I'll just add, thanks for the opportunity to discuss this. I know I've presented at these webinars in the past, but it's always good to sort of get our message out and just know that we're doing the best job that we can. And our system, it's well known to everybody that our system, whether it's in hospital or pre-hospital, is in a crisis, and we're actually just trying to keep our head above water and do the best that we can. And so if you're concerned about something, or maybe something didn't go right, or you thought that it should have been a LifeFlight launch, or you thought it should have been a trauma team activation, like just shoot me an email or a text or whatever it is, and I'll answer your questions and your concerns and try to get back to you as best I can. But again, it's always doing the best for your patients. And if you really believe that this patient needs to be transferred, whether it's by LifeFlight or trauma team activation, then it's make the call and have that conversation with the people who are working and who can make those decisions to get that patient to where they need to go. That's basically all I got to say. But thanks, Andrew, for the invite.
Thanks for the presentation, Steve. It was great. Thanks for everybody who attended as well. Lots of great information, and like I said, just a good overview again for those that may not be all that familiar with our transport and how we have a trauma activated across our province. And as you talked about, our province is very unique, where regional centers are, where our tertiary center are, and that can often cause some issues with trying to get to the patient where it needs to be as fast as we possibly can get the patient there for best care. Okay, thanks everybody.
Perfect. Thanks, guys.